Great turnout, guys. Right.
Mr. Dawson Bowling's here as well.
Mr. Dawson Bowling.
Medial is very kind, thank you.
Was Lady Diana?
Right.
Introduction about Christmas.
Right, unfortunately my talk isn't very exciting. Staff has allocated the interesting topics to really bad way. So anyway,
hang on, that's my own thing. What do you do?
Right, so I'm going to talk about arthroscopy anatomy and my diagnostic routine. So these are the points I'm going to cover in this brief presentation. So talk a bit about the anatomy of the knee joint and the indications to do any arthroscopy, and then how to place the portals, how to perform an EUA, and some diagnostic pictures at the end. So I think it's very important to have a good knowledge of the anatomy of the knee joint before doing arthroscopy. To understand that there are three main compartments in the knee. The articulation between the tibia and the femur, the two compartments, medial and lateral, and then the patellofemoral joint. So having an in-depth knowledge of the anatomy of the joint is important to know what you're looking for and what pathology you may find. So in terms of why we do any arthroscopy, although the vast majority of cases are done for therapeutic purposes and treating pathology, I think diagnostic arthroscopy still has a role in modern orthopedics, in surgery. I think you always, every now and then, you'll face cases in clinic where you've done your imaging, you've done a good clinical examination, and you're still not sure what's going on. So arthroscopy would be a good next step. Sometimes you perform an intervention, you repair a meniscus, or you do microfracture for an osteochondral defect, and patients still have symptoms 6 months, a year down the line. So again, another arthroscopy would be useful in these situations. And sometimes you need tissue specimens from the knee. Your rheumatology colleagues may ask you to, they're investigating someone with some sort of arthropathy, they're not sure what's going on, and a tissue specimen may be required to confirm the diagnosis. In terms of therapeutic cases, I've listed here the main ones. So loose bodies, someone presenting with locking of the knee, and you can see those loose bodies on the MRI, and you need to scope them to remove these loose bodies. Operating on meniscal pathology, cartilage, injuries. Maltracking, lateral release. It's very effective to do arthroscopic lateral release without having to open up. And ligament work as well. So I do arthroscopies, under GA. I use a tourniquet. I believe using a tourniquet improves visualization during the operation. And I know that some surgeons don't use a tourniquet. Some people nowadays don't use a tourniquet even for ACL reconstructions, for instance. So that's open to debate, I think. So I use a tourniquet. I do the arthroscopy with me standing. And again, I know some surgeons do it, sat in a stool. I find that you control the leg better if you're standing. The height of the table is approximately kind of my height. I just need to make sure that the leg sits comfortably on the side of my pelvis, and that's to apply some valgus force when I'm checking the medial compartment. I don't use a foot bolster routinely. Some people do to hold the knee in flexion when you're doing parts of the operation. I think every arthroscopy should start with an EUA. I think it's an important part of the operation. It allows you to assess a number of things. So these are the things I do when I perform an EUA. So I check the range of motion, document that clearly, note any fixation deformities, stiffness, limitation of flexion, and then assess the PCL, ACL, the PCL, and the collaterals. The pivot shift in particular is a very useful test, and it's difficult to perform in clinic. And I find it much easier to do in theatre under GA. So you've done that, you've done the EUA, then you proceed to the arthroscopic procedure. These are the two standard portals that we tend to use most of the time, so anterolateral, anteromedial. In terms of orientation of the incisions, some people go horizontal, some people go vertical, some people go oblique, so whatever you're comfortable with. I think when you're starting to do arthroscopies, it's important to mark the anatomy, so mark your tibial tubercle, patella tendon, patella, and the joint line. And you're aiming to be about a centimeter above the joint line to avoid the meniscus. You start obviously with the lateral incision first, get that lateral portal done, and then the medial portal you can then make the incision while you're looking at it from the side of the knee. So these are the standard portals. There are many described additional portals that you can utilize for more complex operations. So if you're repairing meniscal tears or doing multi-leg reconstructions, you can use these accessory portals. I routinely use an accessory anteromedial portal for my ACL reconstructions, so I'll have a far medial one as well. So they are useful. I guess the point to mention here is that if you're going to use a posteromedial or posterolateral portal, you need to understand the anatomy around the back. So posteromedially you need to be careful with saphenous nerves nearby, and laterally the common peroneal nerve, obviously. So in terms of what you see, so you've created that lateral portal, you're inside the knee, then you retract the arthroscope a little bit and you extend the knee, and you're trying to get into the suprapatellar pouch. That's where it starts. And that's a good place to look for loose bodies. And it's also a good place to obtain a synovial biopsy if you've got synovitis. And then you retract the scope a little bit and you're aiming to get into the patellofemoral joint. It's important, I think, to look at the trochlea and the patella clearly. With the patella, make sure you look at most of the articular surface, the facets, medially and laterally. Same thing for trochlea. If you have issues with tracking, or you're worried about tracking problems, you can do a dynamic test here. You can flex the knee a little bit and see how the patella track in the groove. And then note your findings clearly. So I see a lot of operation notes where people make a brief operation, they don't describe what exactly the findings are. So any cartilage defects, arthritis, graded, describe it well, because the idea is if people are looking at this operative 2 years down the line, they need to be able to make a decision based on your findings sometimes.
With regards to the op note as well, it's quite useful to have a one-line summary plan at the end as well. Yeah,
exactly, at the end, like if you feel a patient would benefit from a uni, for instance, it's just make that clear, just say it. In a busy clinic, it's very good when you see an op note and someone's made a provisional plan in theatre. So after looking at the VFJ, I go medially, so I look in the medial gutter. Again, you can find loose bodies there. And then I enter the medial compartment. And at this stage, I'm thinking of extending the knee and applying some valgus force to open up the medial compartment a little bit. So again, the main structures to look at are the medial femoral condyle, the medial tibial plateau, and the medial meniscus. With the meniscus, make sure you see the posterior horn, the body, and the anterior horn. And if you find a tear, again, know how to describe a meniscal tear. So again, it's very common to see meniscal tear without description of the extent of the tear or what part of the meniscus involves. So be clear about it. It's anterior horn, it's body, it's pocket handle, it's vertical, it's horizontal. So that's also very useful in terms of making a plan. After that, I look at the notch. Very commonly, you'll find the ligamentum mucosum covering the ACL, and you'll be looking at it and thinking, I can't see, I don't know what's going on, so I just need to use the shaver a little bit to clear with that. The fat pad may be on the way here as well, blocking the view, so you may need to remove a bit of the fat pad. And then, try and get the ACL, check its stability, its tension, so use a probe, and look at the attachment on the femoral side, because that's commonly where it fails when people get an ACL rupture, just the femoral attachment footprint. So, try and see the notch, the attachment there, and describe what you see, take some pictures.
Sammy, just on that picture, it's interesting. Sorry to interrupt. The two things that people miss a lot. People look at the ACL macroscopically and say it looks okay, but you can pull it, you get an empty lateral wall that completely peels off. And the medial meniscus is the other thing. If you don't get the hook underneath and flick it, often you get a flipped meniscus underneath that's causing all the problems.
Yeah, so I agree 100%. A thorough examination. So use the probe. just check every part of the meniscus, every part of the ACL. Just the idea of doing the operation is to find out what exactly is going on, so you can formulate a plan, an effective plan. So again, you can see a bit of the PCL. The ACL is in the way, but again, you can go down the way and you can see the PCL behind it. You can also find loose bodies in the notch, so have a good look. And then in terms of getting to the lateral compartment, some people struggle with this. So what I tend to do, I pull the probe out, and because the lateral compartment starts here, so I just position the probe in the lateral compartment, and I keep it on the screen with arthroscopy, and I gently bend the knee and go to figure 4, and then that opens up the lateral compartment. If you get lost, always go back to the notch. I think that's easy, and then enter the lateral compartment from there. So same thing laterally. You need to look at the lateral femoral condyle, the plateau, and the lateral meniscus. Use a probe, check the body, the posterior horn, the anterior horn. Again, a thorough examination is very important. Find a tear, as I said earlier, describe it well. Make a decision as to whether you will repair it or put around it. That's it really.
Any questions? Cool. Thank you, Sammy. I'm sorry it was a long topic, but